All right. A very warm welcome to all the attendees. Thank you so much for being here. I'm JP Janardana Panatapura, one of the co-directors of this program, Academic Radiology Education Program. A very brief introduction for the first-time joiners. Academic Radiology Education Program was, we started this in 2021. This was an idea. Then the first session was in 2022, where we did 28 sessions. It's basically a nonprofit free education program, which is virtual and online. Every 2 Sundays in the month, we do different subspecialty in radiology, and we try to get the speakers from esteemed institutes from the United States. The purpose of this program is to share the experience, expertise, and knowledge from US throughout the world. So this is happening with collaboration of multiple leading hospitals from across Southeast Asia and in Middle East, Iraq, and also from the Wake Forest University School of Medicine. So I again welcome you all for another wonderful session of cardiothoracic radiology. Very essential, this topic. We're going to be talking about lung RADS, and I want to welcome our speaker who actually does not need any introduction. She is internationally renowned authority in lung cancer screening, Dr. Carolyn Childs. She's professor of radiology at Wake Forest University School of Medicine. So she did her medical school at Duke in 1976, followed by residency at Stanford University in 1980. Then she continued to do her fellowship in thoracic imaging in 1984. That's also from Duke University. She is a great teacher and an amazing educator. She has multiple, she's done multiple review articles, like more than 150 review articles, nearly more than 300 lectures throughout the globe. And she served as a section chief in cardiothoracic imaging at Wake Forest University School of Medicine from 1996 to 2013. She was on editorial board for Investigation Radiology, Chest Film Clinic, and she is a reviewer for many esteemed peer review journals. And she has multiple member of multiple national committees and council appointments. Very notably, she was the co-chair of Thoracic Committee in ECOG Akron. And she's got numerous awards and achievements. Very important of them is that she served as a president of Society of Thoracic Radiology from 2019 to 2020, and then she was awarded the Lifetime Achievement Golden Award at STR in 2023. Again, I would like to welcome Dr. Childs to talk about the lung RADS. Welcome, Dr. Childs. Over to IT, please.
Thank you so much, JP. Happy to be here.
Can we have the video, please?
I'm Caroline Childs. I'm a professor of radiology at Atrium Health Wake Forest Baptist Hospital in Winston-Salem, North Carolina, in the United States. Thank you for being here today. I'd like to share with you our experience with lung RADS. Lung RADS is the reporting and data system that we use for interpreting our lung CT screening examinations. This was developed by the American College of Radiology. I think it's very useful. Even if you do not have active screening programs within your hospital or even within your country, I think you'll find that the principles of how to manage nodules in patients who are at risk for lung cancer will be applicable to any CT you do, not just a screening CT. So let's get started. First, I have to disclose I am a consultant for the Optellum Incorporated company. Shouldn't have any bearing on this talk. All of these clinical images are my own. I have a few graphics that I've given you the references for. In the United States, the current guidelines for screening is a patient should be between the ages of 50 and 80. They should have a smoking history. They could be currently smoking or former smokers, and with a history of at least 20 pack years. So that's typically a pack a day for 20 years. It could be 2 packs a day for 10 years. It could be half a pack a day for 40 years. But we should have at least 20 pack years in order to be eligible for lung cancer screening. Now, we used to use a quit time. They had to have quit within the last 15 years. Recently, we removed that from the eligibility criteria because patients remain at risk even after they've stopped smoking. Even though their risk for malignancy shouldn't increase based on smoking, it increases naturally with age. So we feel that we should still be screening these patients regardless of their quit time. So lung RADS, the RADS refers to the reporting and data system, just an acronym there. And we use this for other things. We use it for mammography. We use it for pancreatic imaging and thyroid imaging and prostate imaging. So this is the American College of Radiology reporting and data system to help keep all of the radiologists who are reporting these examinations working within a defined framework so that there's consistency whether you go into a hospital in one part of the country or another, whether your CT is read by myself or one of my colleagues, that there's a standard approach to the examination. You'll see that we have had 3 different versions of lung RADS. The first was released in 2014, and this was just as we were beginning to launch screening on a clinical basis within the United States. We wanted to get this out there before people really started clinically screening. The second version was released in 2019. We learned a lot with the data that we collected in those first 5 years, and we want to constantly be fine-tuning lung RADS so that it helps us find lung cancers early and act on lung cancers early, and yet not do more workup than is necessary. We don't want to cause undue anxiety. We don't want to increase expense when it's unnecessary. So we're constantly fine-tuning lung RADS to help us better interpret and report these examinations, and really to help guide management for the findings. Most recently, lung RADS version 2022 was released just a couple of years ago. So let's start with how we started in the beginning with lung RADS version 1. In this, we defined the attenuation and consistency of nodules that we would see on a screening CT as either solid or part solid or non-solid. You'll see that we use the terms non-solid and ground glass interchangeably. So you can use either phrase. I like non-solid, but you'll see that we use those interchangeably. So here's an example of these 3 different nodule types. On your left, you'll see a solid nodule, which is the most common type of nodule that we're going to encounter. And you can see we can't see through it. It's a solid nodule, typically spherical in shape. We encounter these all the time. They're quite common. Next to that, you'll see the part solid nodule, and this is a mixed attenuation nodule. And you can see in this example, we have a solid component in the center. It's surrounded almost by a halo of ground glass attenuation, and because of this mixed attenuation, we call this part solid. On the far right is a non-solid or ground glass nodule. Ground glass was a phrase sort of developed to say we can see through this. So it's almost like ground glass. We can see through it still. We can see vessels through it. We may see air bronchograms through it. But this nodule has some translucency to it in contrast with the solid nodule. We can't see anything through that, with part solid being a mixture of those 2 types of attenuations or consistencies. Here's some examples of solid nodules. You'll see here on the top left, This one has some spiculation, so it has some malignant features, but I really want to show it as an example of solid nodule. We can't see through it. Because of these additional features of spiculation, this sort of notch within it, I think this has a very high likelihood of being malignancy, as does this lesion on the top right, also with spiculation, solid nodule, very high likelihood of being malignant. On the other hand, this solid nodule doesn't really have additional features of malignancy, and as I mentioned, most solid nodules are benign. This nodule at the bottom, you can see here on lung windows, is adjacent to a major fissure. And when we look at it on soft tissue windows, we can see that it does have high attenuation, that of calcium. So this really helps us determine that it's benign. When you're looking for the presence of calcium in a solid nodule, you want to do this on the images that you have that have the least noise. And this will typically be your images that are reconstructed using a soft tissue or standard kernel. These will be the least noisy images and will give you the best way of evaluating the internal attenuation within this nodule. When we can see calcification such as this, we know that this nodule is benign, it's likely a granuloma, and no further workup is necessary. So whenever you can, do check to see if you can find calcification within a nodule, because again, we commonly encounter these. We do not want to trigger a diagnostic workup in patients who do not need that. We do not want to waste time or medical resources on these nodules that have clearly benign features. So most of the solid nodules we encounter will either be benign or perhaps indeterminate, and then some of them will have malignant features that increase the likelihood that these are malignant. This is an example of part solid nodules, and I have 6 different part solid nodules here, and you can see that they have something in common. They have both a solid component, in this case it's somewhat eccentric, with sort of a ground glass component on this side. Similarly here, a small solid component, ground glass around, solid surrounded by ground glass. This one not so much ground glass, but you see we've got some clustering bronchioles in it. So remember that lung cancers can have some cicatrization, some scarring that pulls the features of the lung together. So sometimes you'll see that as clustering of the architecture. Sometimes you'll see it as distortion of an adjacent fissure. And another part solid nodule which has some solid, some part solid, and these clustered bronchioles. Another solid, somewhat ground glass component. Now, unlike solid nodules, which are overwhelmingly likely to be benign, part solid nodules, on the other hand, are the ones that are most likely to be malignant. And all of these turned out to be malignancies, typically an invasive adenocarcinoma. So you want to, when you see part solid nodules, these are going to be suspicious and very concerning for malignancy. So these are the ones I worry the most about. On the other hand, here are non-solid nodules, also called ground glass nodules. And the feature of a ground glass nodule is we can see through it. We can still see vessels, maybe a little bronchus there. Similarly, we can see these bronchi. It's ground glass here with some vessels in the middle. This one, I don't blame you if you think, oh, I don't know, maybe that's part solid. Maybe there's a little bit too much solid component. And this is where sort of science meets art, and there's some judgment here. Do I call this part solid? Do I call this ground glass? If I'm on the fence, I'm going to err on the side of part solid. Part solid nodules, very likely to be malignancy. I don't want to miss one. So these, although I feel confident that these are non-solid ground glass nodules with a low likelihood of malignancy, very likely to be stable over year to year. This, on the other hand, if you want to call it part solid, I'm thinking that might be reasonable. Here's a really nice example of a pure ground glass nodule. We could see a vessel through it. We could see an air bronchogram. And generally, these do not grow over time. They might look like this forever. Here's one that's also a little bit higher attenuation, and you could argue, this has got a lot of high attenuation to be just ground glass. And so what really will help you is to look at these lesions over time. If this is my baseline and then I saw it become higher in attenuation, I'm going to call that growth, and I'm going to change how I read this. If, on the other hand, this is my first CT, I'm going to call it a non-solid. I'm going to recommend that they keep coming back. So you could see there's some judgment, purely ground glass, purely ground glass, purely ground glass, purely ground glass, and I don't know, maybe I should have put these on the other slide. So these are the dilemmas we face as we're deciding whether something is non-solid or part solid. But again, if you're on the fence, go with part solid, because that's going to trigger closer follow-up, and we certainly don't want to miss an early lung cancer. So the very first version of lung RADS, in addition to defining the attenuation and consistency, it established size thresholds for each nodule type, solid, part solid, non-solid, as determine whether they're benign, they're probably benign, or they're suspicious. So let's look at those. So here we have at the top our solid, our part solid, our non-solid nodules, and then these are the categories. So to consider a solid nodule benign, I need it to be smaller than 6 millimeters in diameter. Part solid nodules, similarly, you can see I will allow a non-solid nodule. In this first version, we used a threshold of 20 millimeters. As I will show you in a little bit, we've upped that threshold to 30 millimeters. So we sort of have a hands-off approach to non-solid nodules, and we'll talk about that debate in a few minutes. So less than 6, we're going to call these benign. Now, once it reaches 6 millimeters, we're going to move up from benign to probably benign, as long as it's smaller than 8 millimeters. For a part solid nodule, I want to introduce the concept of two things. One is the idea of a total diameter. So when you measure a part solid nodule, you can measure the total diameter of the nodule, and you can also measure the diameter of the solid component. Now you can see that not all nodules are perfectly spherical. They're not perfectly round on cross-sectional imaging, and so you might want to measure two diameters, the long axis diameter and the short axis diameter, and then determine the mean diameter. So let's say that this was 8 millimeters in this direction and 6 millimeters. I would say then the mean diameter is 7 millimeters. And yet, so my total diameter might be 12, but my solid diameter might be a mean diameter of 7. So that's how I would approach this lesion. The reason we do that is because the solid component is what's really actionable. If I want to biopsy this, or if I want to get a PET scan, I really need that solid component to be at least 6 millimeters, preferably even 8 millimeters, in order to know that I'm going to have a good chance of an accurate PET CT or a true positive diagnosis on bronchoscopy or biopsy. So suspicious, we're going to bump our size thresholds up to 8 millimeters for solid nodules. So once a solid nodule is 8 millimeters or greater, we're going to consider it suspicious. Again, we're going to use that solid component when we're looking at a part solid lesion, and we're going to look at a solid component of 6 to less than 8 millimeters. Again, notice that non-solid nodules can never be considered suspicious. And we'll talk about what they have to do to become suspicious, but it's not based on diameter. Very suspicious nodules, 15 millimeters in diameter or greater. If it's part solid, if the solid component is at least 8 millimeters. So these are the size thresholds defined by the first version of lung RADS to define nodule attenuation and consistency thresholds. We also have a number that goes with that. So this is introducing the concept of lung RADS scores. So these benign solid nodules, less than 6 millimeters in size, lung RADS 2, benign. part solid, less than 6 millimeters, lung RADS 2, benign. Once we go up in size, we're going to go up to probably benign. We're going to use our lung RADS 3 category. Once we get up to 8, it's suspicious. We're going to bump it up to lung RADS 4A. Once it gets up to 15 millimeters, we're going to bump it up to very suspicious lung RADS 4B. So just keep in mind that anything that's a lung RADS 4 is considered suspicious for lung cancer, suspicious for neoplasm. So these are ones that we're going to really want to keep an eye on and make sure they're worked up correctly. Now, the first version of lung RADS defined some additional things. One is it said when we measure a nodule, as we just showed you, we measure it in 2 dimensions and we report the mean diameter. So many nodules are spherical. They're circular on cross-section. They're 6 millimeters in diameter, no matter how we measure them, and we just need to report the 6 millimeters. On the other hand, if they're more ovoid in shape, we're going to measure the long axis, the short axis, add those up, divide by 2, and report the mean diameter. And that, when we look at our lung RADS chart, to say, is this probably suspicious? Is this suspicious? Is this very suspicious? We're going to use that mean diameter to determine which category we belong in. Lung RADS 1 also estimated the probability of malignancy for each of these categories. We've subsequently taken that out, and I'll show you that in a minute. It also listed the estimated prevalence of your cases considered benign, probably benign, and suspicious in a screening population. Basically, 90% of the exams that you read in a screening population will be considered benign or probably benign. So they'll be considered lung RADS 2 or 3, whereas 10% will be considered suspicious. The most important thing, one of the most important things about lung RADS version 1 is it defined the management for each category of nodules. The way to effectively screen patients is not just to find the nodules, but to make sure we work them up in the most expeditious manner. So we have an aggressive workup for people with a very high likelihood of malignancy, and we have sort of a watch and wait sort of observational approach to ones that are much less likely to be malignant. So this defined management helps us all stay on the same page, and I think it helps us as we communicate with the patient's primary care provider. So let's look at what these management guidelines are. I just want to introduce to you the concept of zero incomplete. Sometimes you'll read a CT where, oh, we didn't get all the way through the lung basis. We're going to bring the patient back and we're going to scan through the lung basis. Or we need some additional imaging. We know the patient had a scan last year. Let's give this a 0. Let's hold it and reread it once we get those comparisons. So that gives us a way of not assigning a lung RADS till we get that additional imaging. Category 1, negative, means they had no nodules. We're just going to bring them back in a year for their annual screening CT. Similarly, benign nodules, remember these are solid nodules less than 6 millimeters in mean diameter. We're going to, again, continue annual screening with low-dose CHISI in 12 months. Once we've moved up to probably benign, so now we've moved up to a solid nodule that's 8 millimeters, or we have a part solid nodule with a solid component of at least 6 millimeters, we're going to bring them back in 6 months. So they're not suspicious enough to bring them back sooner or go ahead to tissue sampling, but they're more suspicious than if we had considered them a category 2. So these are mostly going to be benign, but we're going to bring them back in 6 months just to take another look. Now we're moving into suspicious category 4. For A, we're going to follow them up with a low-dose chest CT in 3 months. If the solid component would allow, you could consider a PET CT at this point, depending on whether or not you think you've got enough solid material to generate a positive PET CT. 4B, very suspicious. At this point, we have multiple options. You could get a diagnostic chest CT at that point. generally what we're going to do in my institution is we're probably going to want a PET CT and tissue sampling. Sometimes we'll do the tissue sampling first. Other times when we see lymph nodes already, we might do the PET CT first, which will help guide bronchoscopy and help us determine what nodes definitely need to be biopsied. 4X, additional findings that support a malignant diagnosis. For example, I see a mass in the right upper lobe, and in addition, I see right paratracheal lymphadenopathy. Or I see a nodule that would normally be considered 4A based on size. Let's say it's only 9 or 10 millimeters in size, but I've got spiculation. I can bump that up to a 4X. So a spiculated nodule, maybe I don't want to bring that back in 3 months. Maybe I want to call it a 4X, with a much more aggressive workup. So 90% of the exams that we read in a screening population, and we're currently doing over 100 screening CTs a week in our system, about 90% of them are going to be category 1 or 2. So both of these could be considered benign or negative results. 10% of the cases that we read would be considered category 3 or 4. So these are ones that are going to require additional follow-up. It might be additional imaging, could be a PET, we might go on to bronchoscopy, but only 10% of the cases we're going to encounter will need that additional imaging. This was just a bird's eye view of version 1 lung RADS, the first version that came out, and very, very busy, which is why I sort of walked through it the way we did. And you could see probability of malignancy was reported on that one. This has been removed because this probability of malignancy was based on population data. So for example, if you took 100 patients with category 4A, suspicious, the probability of malignancy in that group of 100 patients would be 5 to 15%. But that's not patient probability, that's population-based numbers. So that's sort of misleading. You know, if you've got a patient with a suspicious nodule, there might be characteristics that make you think that the probability of malignancy is extremely high. So this really isn't relatable to patient data. This is population data, and that probability of malignancy has been removed from updated versions. So let's look at the next version of lung RADS, which came out in 2019, version 1.1. And this added periphyseal nodules to the benign lung RADS 2 category. So periphyseal nodules, as you know, are typically attached to a fissure. Could be the minor fissure, major fissure. They're homogeneous, they're solid, they have smooth margins, and they're either oval or lentiform or triangular in shape. This is from the Nelson Group out of the Netherlands, and this is one of their papers showing typical periphyseal nodules. They also encountered atypical periphyseal nodules, which were also benign. They have a little bit more of a convex margin, or they weren't attached to a fissure. So what lung RADS, the next version 1.1 did is said, well, these are benign, but because of their diameter, we're having to consider them category 3, which is generating unnecessary workup. So they redefined periphyseal nodules to say, if it's a classic looking periphyseal nodule, you look at this and you know it's a periphyseal nodule, you could measure up to 10 millimeters in diameter and still be considered category 2. And this has been updated to the mean diameter of the nodule could be up to 10 millimeters, and now we can back down to that just being a category 2. So even though we're using a threshold of 6 for solid nodules, when it's periphyseal, we change the threshold. We also changed the threshold for non-solid ground glass nodules. As I mentioned, we moved it up from 20 millimeters to 30 millimeters. So if it's under 30 millimeters, unchanged or slowly growing, category 2, benign, This is going to be followed up in 12 months. We're going to take a look at it at the next annual screening CT. And what we're looking for is we're looking not so much for growth of the nodule, we're looking for a solid component. And that's what's telling us it's become an invasive adenocarcinoma. So that's what we're looking for. We also use a category of 30 millimeters now if it's more than 30 millimeters and present on baseline or new, we'll bump it up to a category 3. So when it's that large, we're seeing it on the baseline, we're going to do a follow-up in 6 months is what our category 3 will generate. I will say that this data is it's been to a large extent based on the international LCAP, the Early Lung Cancer Action Program data, who have really found that these non-solid nodules tend to be benign, and they really should be managed with observation rather than with intervention. So that we're not resecting lung in a patient in which this was not going to be a cause of mortality. We'll say there is data saying now that these non-solid nodules in Asian women are much more likely to be invasive tumors. And so it is possible that in different populations, we do want to be more aggressive with non-solid nodules. I think no matter what, you want to follow them and make sure they don't develop a solid component. But it could be that you feel in your population that earlier resection is warranted. We added intrabronchial nodules. You can see this nodule in the left lower lobe bronchus. So this was not in the first version, so we added intrabronchial nodules to category 4A. We added the concept of infectious and inflammatory nodules to category 4. Let's say a patient had a screening CT last year, they come back this year, and now you see a fairly large nodular mass, and you think this has grown too fast to be tumor. I could get a follow-up CT in a month to see if it's potentially infectious or inflammatory. So here's the bird's eye view of lung RADS version 1.1, rather colorful, a little fleshed out, so you can see these are busy. You want to keep a copy of these close at hand. But let's move on to the current version lung RADS 2022. And this is, we've made some additional revisions, again, trying to make sure that we're identifying lung cancers early and we're managing them appropriately. In lung RADS version 2022, periphyseal nodules were further refined to include all juxtapleural nodules. So not just those adjacent to the interlobar fissures, but those up against the mediastinal and chest wall pleura. And if they're a typical appearance of a juxtapleural nodule, again, we can use that 10 millimeter threshold. So here we are, if juxtapleural nodule considered category lung RADS 2, benign, if it's under 10 millimeters in mean diameter at baseline, solid, smooth margins, oval, lentiform, or triangular in shape. So that's really helping us take a much more hands-off approach to nodules that you're going to look at and say, oh, these are clearly benign. So here's some examples. Here's a case. Here we have the major fissure down in the right lung base, and we can see a somewhat triangular. This one over in this patient's a little bit more of a triangle nodule up against the fissure. You're going to look at this and say that's a periphyseal nodule. As long as it's less than 10 millimeters in mean diameter, I could consider this category 2. Here's one that was sort of interesting because at first glance on axial view only, you could get a measurement of 10 millimeters and be considering category 3. On the other hand, when you do these coronal and sagittal reformats, you could say, oh, this is a classic periphyseal nodule. Here's our minor fissure. It's triangular in both views. It's a classic periphyseal nodule. And again, when I measure not just the maximal diameter, but the mean diameter, I can get that mean diameter to be less than 10, classic appearance. We can call this a lung RADS 2 with no further short-term follow-up recommended. We'll bring them back in a year for their next screen, but this is a typical periphyseal nodule. Here's two in the same patient. Now this one I think checks all the boxes. I think it's up against the fissure. It's triangular. This one, on the other hand, although it is juxtapleural, the angles are a little bit acute. And so this one I might not be willing to call a benign juxtapleural. I might want to go ahead and say, I might want to consider this a solid nodule and then define that based on size. It's probably going to come out to a lung RADS 2 either way, but just uh, be aware of the attachments with the pleural surface. Here's some examples. On the right, I say, oh, here's a nice triangle that's juxtapleural. Here's sort of one that has obtuse margins. It's lentiform, again, sort of obtuse margins with the chest wall. But these have acute angles. Here's acute angles with the chest wall. And so these are more worrisome. These may not be classic juxtapleural lymph nodes. These may be true nodules. So just pay attention to the angles with the chest wall. Here's some classic juxtapleural nodules. Again, really encourage these reformats. Sometimes you can see that something's juxtapleural in one view, and it may not really be clear on additional views. Lung RADS version 2022. Remember when we had a potentially infectious or inflammatory lesion, we put it into category 4. Well, with category 4, the patient is likely to get a phone call or a letter saying you have a suspicious lesion. Well, that's just causing unnecessary anxiety because we think it's infection. So we don't want to tell the patient they have something suspicious. We want to say you have something that could be infection, and we want to bring you back maybe in 6 weeks and see if it went away. Maybe we want to communicate with your primary care provider that they could start you on some antibiotics and see if this goes away, see if you've got any symptoms of infection. So now we've moved that to category 0, which was incomplete. So now category 0 includes an incomplete exam, one that we're waiting for additional imaging, or one that is potentially infectious or inflammatory. So here's patients, some examples of ones where we would use the lung RADS 0, segmental or lobar consolidation, a patient with multiple new nodules, but at least more than 6 in number. So this is like what might fit under that is, let's say you think they've got metastatic disease, you might want to call that a lung RADS 0 because there's multiple new nodules, but they're not really suspicious for a primary malignancy. You're thinking about metastasis. And so I'd say lung RADS 0, category S, significant other finding. So a large solid nodule, as we mentioned, appearing in a short interval, new nodules, perhaps in an immunocompromised patient. So these don't really look like lung cancers to me. I'm going to give them a lung RADS 0, get a very short-term follow-up. It could be 6 weeks, 8 weeks, 12 weeks, and just see if these go away. Another example where, gosh, do I want to call this a part solid lesion? But if I look at other parts of the chest and I see that there's tree and bud opacity and multiple different lobes, maybe instead of a part solid, maybe I want to consider maybe this is infection. Similarly, with this patient, this sort of looks more like tree and bud opacity. Is this a primary lung cancer over here, or is this related to this infection? Does this patient have atypical mycobacterial infection? So I might give this a 0. We're going to bring this patient back. We're going to talk with the patient's clinician. Sometimes patients who have lungs such as these with chronic lung disease due to atypical mycobacterial infection are not well suited to lung cancer screening programs because we're going to be bringing them back every 3 months looking at these nodules. So there might be a better way to manage these patients. Remember, if you are looking at something that could be either malignancy or infection, stick with with lung RADS 4. So if malignancy is more likely than infection, stick with lung RADS 4. 50-50, I'd probably still use lung RADS 4. I don't want to miss a lung cancer. On the other hand, even if I think it's infection, we're bringing them back on a short-term basis. So LungRADS version 2022 redefined endobronchial nodules as airway nodules. If they're subsegmental or smaller, it's considered category 2. If they're in a segmental or more proximal bronchus, so segmental, lobar, main, bronchus, trachea, category 4A. So remember, here's our Boyden classification for bronchial anatomy. If the endobronchial nodule is segmental, lobar, main bronchus, or in the trachea, we're going to consider it LungRADS 4A. So if we see this for the first time, we're going to call it 4A. That's going to trigger a 3-month follow-up, and we're going to look again. If it's persistent, we're going to bump it up to a 4B. That's probably going to prompt bronchoscopy. Based on the appearance, sometimes we'll do bronchoscopy at the first sign. Sometimes we'll wait and see if it persists on follow-up. Here's a couple of examples. I want to call this mucus, but I don't really see that bubbly appearance, and so I have to call this lesion of the trachea of 4A, this in the left main bronchus 4A. So we can bring them back in 3 months, see if it clears, or you could decide to go ahead and do bronchoscopy based on your index of suspicion. Again, that patient that I showed you, this turned out to be a endobronchial hamartoma in the left lower lobe bronchus. Here it is in the left lower lobe bronchus. So this would trigger a LungRADS 4A, a lesion such as that. Sometimes the airway nodules will be more distal, and they'll be associated with other evidence of tree and bud, and you're going to favor that this is an infectious process. At that point, you could either use your LungRADS 0, likely infection, or you could call this subsegmental airway disease LungRADS 2. You can go either way on this. LungRADS version 2022 also added the category of atypical pulmonary cysts. So we've learned a lot as we've screened over the last couple of decades, and we've learned about atypical lung cysts and their likelihood of becoming malignant. So a thick-walled cyst is considered an atypical lung cyst. You can see that this is a unilocular cyst with uniform wall thickness. This one actually has some wall thickening and nodular wall thickening, which will make it be considered atypical. In contrast to a cavitary nodule where the solid component is the dominant feature, with an atypical lung cyst, the cystic component is the dominant feature. So I would consider this a thick-walled nodular wall. This is an atypical lung cyst. Here's a multilocular cyst, which is considered atypical. We can see multiple loculations. There's even a little solid component. We're going to consider this an atypical lung cyst. Now, a thin-walled cyst, such as this, there's no nodularity, the wall thickness is less than 2 millimeters, it's uniform. We're going to consider this benign. Here's another one up here. And we're not even going to include it in the LungRADS. This is a benign finding. Now, this is an article out of Japan in 2006. It's the first report I can find of lung cancers associated with cystic or bullous lung lesions. There were articles prior to this that talked about the chest radiographic appearance, but this one in 2006 was the first one that I could talk really about the CT appearance. And they came up with these 3 classifications. We could have a bullous lesion with an exophytic nodule extruding from the bullous lesion. They call this type 1. The nodule could be endophytic, sitting within the bullous lesion, type 2, or it could be a thick-walled bullous lesion, type 3. Subsequent to this, a group out of Italy by Dr. Mascalco and his colleagues said, okay, we agree with this. We agree with your type 1 exophytic, your type 2 endophytic, your type 3 thick-walled cystic space, but we're also seeing multi-cystic clusters of cystic air spaces, and they added type 4. I'm also going to recommend this article in Radiographics in 2018, which is really excellent. And I've used their illustration here to show you the type 1, type 2, type 3, type 4. I don't think it's important to really know the different types. I think it's most important to be familiar with the different appearances so that you can have the necessary index of suspicion. So here we are in Lung RADS version 2022. 4A includes atypical pulmonary cyst, thick-walled cyst or multilocular cyst at baseline, or a cyst that becomes multilocular over time. 4B, even more suspicious, would be a thick-walled cyst where the wall thickness gets thicker or more nodular. The multilocular cyst increases in size, or we have new opacity within the multilocular cyst. So let me show you some examples of these. So here we are at baseline. We have a multilocular cyst, and I will say that for many, many years we saw these lesions and weren't really sure what to do with this. So now we're going to call this a multilocular cyst at baseline, Lung RADS 4A, which means we're going to get a 3-month follow-up. This patient was followed up much later. This was more than 3 months, because for a long time we didn't know the right follow-up for these. And now you could see he's developed this exophytic nodule. So he's moved into the 4B category because of this growing exophytic nodule. And this is the likely time course for patients with multilocular cysts. They're very likely to develop a solid component and to represent adenocarcinomas. Here's another case where when I first saw these, especially back when we were doing the National Lung Screening Trial, I wasn't sure what to do with these. I called them bubbly lesions. Now we call them atypical lung cysts. And you can see there's not really much of a solid component, so probably not going to be amenable to biopsy or PET. But when you bring these back, over time you will see that they will develop a solid component. Now we can do a biopsy. Now we can do a PET scan, and we're going to determine that these do represent malignancies. You can even see how this is distorting the major fissure. Whenever anything is distorting a fissure like that, it makes me more likely to think of malignancy. So again, atypical pulmonary cyst. It could be a thick-walled cyst with a growing cystic component, Lung RADS 3. Again, we have these at baseline, thick-walled, multilocular. But 4B is where we're going to be really concerned. So this is a cyst that we've seen already. It's thick-walled or multilocular, and now it's either larger, there's more inoculation, it's developed a solid component, and this is we're going to bump up to 4B. You also have an option at this point to classify it based on the size of the solid nodule. And you could decide how to manage it based on that nodule, whether you want to go to PET or tissue sampling. Another couple of examples. Now here's one at baseline, and I will say when you look at this on actual images only, it's easy to not recognize that this is an exophytic nodule adjacent to the cyst. And then 1 year later, as you can see, that was not recognized. You could see that the solid component is exophytic. It's increased in size. This patient did not come back for another year, and you can see now we have a solid spiculated nodule, very, very likely to be an adenocarcinoma. Based on what we've learned, now we know how to manage these nodules before they get to this size and this appearance. So we can see already growing exophytic nodule. We need to intervene here, not a year later. Another example. Here's a solid nodule, exophytic, adjacent to this cystic lung lesion. Sometimes the cystic lesion pre-existed the nodule. Sometimes the cancer itself creates the cyst. Here's an example of that. Here in February 2015, we saw this exophytic nodule adjacent to this lung cyst. In this patient, we actually had a prior, and you could see 6 years earlier, there was absolutely nothing there. There was no pre-existing cyst. So as this cyst probably developed, it probably developed initially with a thin wall. It became thicker, more nodular, and gradually became like this. So now we understand sort of how these behave over time and can intervene appropriately. LungRADS version 2022 also revised the definition of nodule growth. Previously, we just said if a nodule grew by at least 1.5 millimeters in any dimension, we called it growing. Now we have a time interval. So if it grows now within a 12-month interval by an increase of at least 1.5 millimeters, we'll call that a growing nodule. So if a nodule only grows from 4 millimeters to 5 millimeters, we're not going to necessarily call that growth. It has to have a growth of at least 1.5 to call it growing. Sometimes it's just technical variations that will allow us to see a 1 millimeter difference that really isn't significant. It also defines slowly growing solid or part solid nodules. So let's say we've got a nodule that grows 1 millimeter every year. So it never reaches that 1.5 millimeter threshold. But if we look over 5 years, it's grown 5 millimeters in diameter. So if we're demonstrating that growth over multiple screening exams, and yet it never grew that fast, we could still use our LungRADS 4B category and call this a growing, slowly growing nodule. The other thing that can happen is you might have a nodule that is 7 millimeters, and when they come back, it's 8 millimeters. Well, we really can't call it a growing nodule because it's not 1.5 millimeters, but we would have called that 7 millimeters nodule a LungRADS 3. And now we're going to call the 8 millimeter nodule a LungRADS 4. So you can move a threshold into you could move a nodule into the threshold it belongs. If a ground glass nodule doesn't grow much into size, we could also use this development of a solid component to upgrade that. So here's a ground glass nodule with a small solid component at baseline. At follow-up, the solid component grew. Now we don't really have a change in diameter of the this part solid nodule, but we have a new solid, a growing solid component. So this can be considered growth, even though we don't have a diameter change. Here's another non-solid nodule. This is LungRADS 2. It's less than 30 millimeters in diameter. It's pure ground glass. 10 months later, we get a follow-up, and you can see that the attenuation of this has increased, and so we're going to call this a 4A. This was resected and was an invasive adenocarcinoma. So that's what I'm just sort of suggesting. Look at your population, follow these non-solid nodules, look and see if they develop a solid component. Some people have referred to lesions such as this as heterogeneous ground glass, and that might be a phrase that you find useful as well. I'm going to skip that. We talked about that. Okay, so let's move on to stepped management. So LungRADS version 2022 introduces a stepped management approach. And so once a patient comes back, this will help us decide when to bring them back in. So let me walk you through that. So here's a patient who has a baseline screen, and we find a lesion that warrants a LungRADS 3. And so we're going to bring them back at 6 months. They come back at 6 months. The lesion is stable or even perhaps smaller. We're going to downgrade them to a LungRADS 2, and we're going to bring them back in 12 months. And that 12 months is not from baseline, it's from the 6 months. So now we wait an entire year and bring them back at 1 year after that screen. That's caused a lot of confusion. A lot of people would say, do I bring them back at this 12 months from baseline? But we bring them back 12 months from the most recent follow-up examination. Similarly, let's look at a LungRADS 4A. You know, a 4A, we're going to bring the patient back at 3 months, and let's see what happens. So they come back at 3 months, the lesion's stable or decreased. We're going to downgrade them just one step down. We're going to go down to a lung RADS 3 and recommend a 6 months follow-up. So we're going to do the 6-month follow-up from this time point and bring them back here. Now, what happens when we bring them back at 9 months? So we bring them back at 9 months, it's stable or even further decreased. We're going to downgrade them one more step down from a 3 to a 2, and we're going to resume annual screening at 12 months from this time point. So we're going to bring them all the way back here. So this is a stepped management. Instead of, what I'm sort of saying is, instead of jumping from a 4 to a 2, we're going to step them down from 4 to 3 to 2. If the lesion goes completely away, you had a 3 or 4-way completely away, you can go to a lung RADS 2 and do a 12-month follow-up. If you did a lung RADS 4B, you brought them back and you worked them up, you did a PET scan, you did a biopsy, and you couldn't find anything, you felt that it was proven benign, you found that it was a hematoma or it was a fungal infection, whatever, this patient could also be downgraded to a lung RADS 2 and return to annual screening. One thing I want to finish on is the S modifier. I want to refer you to the American College of Radiology website for this incidental findings quick reference guide. So when we find additional findings unrelated to lung cancer on a screening CT, we add an S modifier for significant finding. This might include an aortic aneurysm, might include coronary artery calcification, it might include fibrotic interstitial lung disease. So we have another of findings that could be considered incidental, and we've developed this sort of one page, if you consider both sides of the page, quick reference guide to help primary care providers know how to manage the incidental findings. I think if you go to the American College of Radiology website and pull that, you might find that useful, and you might just hand it out to your primary care providers to help them know how to manage these patients. Another thing we do, which I think is important, is we have a nodule conference, and every week we go over all of our lung RADS category 4s. We want to make sure that these patients are not lost to follow-up. We want to confirm that they're being managed appropriately and in a timely fashion. It's not enough to just find a lung cancer early. The important thing is treating the lung cancer in a very expedient manner. So we definitely want to make sure that happens with our nodule conference. And we can also make sure that all of our radiologists who are reading the screening CTs are adhering to current lung RADS guidelines. This is a multidisciplinary conference. We have radiologists, pulmonologists, thoracic surgeons. Most importantly, our nurse navigators and our program coordinators are there to help us maintain contact with the patients. I want to thank you for your attention. I hope you find this useful.
Thank you so much, Dr. Charles, for such a wonderful, very educative lecture on lung RADS. You just walked us through from lung RADS, from initiation from 1.1 to 2022 wonderfully, and those extra points regarding how different it is. Thank you so much for doing that.
You're welcome, JP. I hope this is helpful. I know not everyone is screening for lung cancer, but I know that everyone is doing CTs on patients who are at risk for lung cancer. And I think that these principles will help you know how to manage patients who are at risk.
Correct. Awesome. Thank you. And such wonderful illustrations. Those images are excellent. Thank you so much for that. All right, so we open up our Q&A session right now. So if there are any questions, please type them in the chat box or the Q&A box. Meanwhile, Dr. Charles, I have a couple of questions till we have. So we spoke about the mean diameter of the nodule when we measure. So is it the mean diameter in axial sections, or do we have to use 3 dimensions and take the mean?
Right. So for now, it's the mean diameter in the axial section. And we can stop the video. There's some additional slides there, but we could go ahead and stop the video. So right now it's on axial images, and it's measuring long axis, short axis, and developing a mean diameter. We're sort of on the fence about moving into volumetrics and 3 dimensions. So you'll see that in the lung RADS, there are volumetric measurements in addition to the axial diameters. You can see a cubic millimeter measurement. But we know that not everyone has access to volumetrics. So we want to make sure that lung cancer screening can happen anywhere. And even if a system doesn't have the most sophisticated software for nodule analysis, even if you are unable to do volumetrics, you can still work with this. So we're going to start adding more volumetric information, but not require it. You know, we have small hospitals that are doing lung cancer screening. They're not going to have the sophisticated software to do volumetric measurements and volumetric measurement change over time. So we don't want to require that. We'll be adding more guidelines if you do have it, but our goal is to make lung cancer screening available to everyone. And we want to make sure they don't have to drive long distances to get to a site that can screen. We also know that many of the people who are doing these CT scans, interpreting them, are not fellowship trained cardiothoracic radiologists. We want to make this straightforward and widely available so that we can impact the greatest number of patients possible.
Thank you. We have a question. Can we apply lung RADS to normal dose lung CT scan at non-high-risk patients?
So in the US, what we tend to use the Fleischner criteria for incidental lung nodules in patients who may not have been in a screening program. So most of the time I'm going to use Fleischner criteria rather than lung RADS. On the other hand, if I look at the patient's history and I go, ooh, this patient is 65 years old, they have a 50-pack year smoking history, I'm going to probably use management guidelines from lung RADS. I might not give them a lung RADS score. Sometimes I might say, this would be a lung RADS 4A and this type of management, but most of the time I avoid using lung RADS outside of the screening program. And I tend to use the Fleischner criteria instead. And Fleischner criteria several years ago revised theirs so that it really synchronized well with lung RADS, so that we have sort of the same guidelines in these patients. We just use the high risk column for Fleischner Society criteria, and I think you'll find that works well. So I sort of avoid putting a lung RADS on there unless it was part of a screening program.
Okay, awesome. Next question is plain chest X-ray necessary before to do a low dose screening CT? Thank you.
No, it is not necessary. We know that we're going to miss small lung cancers on chest radiographs. So that is not part of, we go straight to CT. We don't need a chest radiograph.
Yeah, right. Awesome. Another question from me, actually. So in patients who had remote history of lung cancer, 10 years back, stage 1, who's been resected, and patient still continues to smoke or have not quit, but we have already taken off the quit criteria from ACS. So do we continue a lung RADS on them, because one of the contraindication for lung RADS is a previous malignancy? Do we still do a lung RADS, or do we go back to Fleischner for the nodules?
So we tend not to include patients who have an active malignancy undergoing treatment in the screening program. On the other hand, once they've been treated, they're 5 years out, yes, they can come back in. So basically, if someone's had a lung cancer that's been resected, we're going to keep them under surveillance for at least 2 years and sometimes longer. And then when they drop out of that surveillance for that initial lung cancer, yes, we want to bring them into a screening program because we know they're at risk for a second malignancy. So we definitely want to include them. So the patients we didn't want to include were patients who really were at risk for metastatic disease, which has sort of different surveillance guidelines. But once that malignancy is not active, it's considered cure, yes, we want to bring them in. So, smoking increases the risk for many malignancies, bladder cancer, for example, head and neck malignancies. And so those patients are very likely to have a lung primary as well. We definitely want to keep them once they've been treated and that, is considered no longer active. We want to bring them into a screening program.
Thank you. Thank you. So regarding the step down or the step management, is there a flexibility for radiologists to, for example, you give it a 4A, it still looks suspicious, but it's stable. You step it down to 3, but it's back in 6 months. It still looks suspicious for the radiologist. Is there any flexibility for the radiologist to say, hey, I'm going to bring it back another 6 months instead of next 12 years?
Yeah, absolutely. Absolutely. And sometimes I'll look at a lesion and I'll think, what do I want to do with this lesion? And I'm going to try to make lung RADS fit to my management guidelines. So our program coordinators look at our reports. And if our management does not fit with the lung RADS, it sort of triggers an alert and they contact us to say, is this correct? Can you just check this? So I want to make sure that my lung RADS score fits with my management guidelines. I don't want to deviate. So yes, if I'm not comfortable with a 1-year annual, yes, I'll stick with lung RADS 3. I'll keep bringing them back at 6 months until I feel comfortable. Because a lot of times we want 2 years of stability before we are feeling comfortable dropping back to a lung RADS 2.
Excellent, excellent. Thank you so much. I guess we don't have any more questions. So thank you so much for such an excellent, educative, wonderful lecture, Dr. Charles. And for the attendees, Dr. Charles is also my mentor, actually. So she's been mentoring me from last 6 years now. And she's an authority in lung cancer. So there can be nobody else who's better than Dr. Charles in answering the lung cancer and lung nodule subject. So thank you so much for taking time and being with us. I greatly appreciate your help and support.
Thank you so much for the invitation, JP and Nat.
Thank
I
you.
really hope that this is useful to the audience.
Thank you. And I'll just hand it over to Dr. Turpaneng Nat. She's going to have a small quiz on the session. Over to you, Nat. Thank you.
Thank you, JP. Thank you. I will share the screen with everyone. So everyone have your cell phone ready to scan the QR code to get your question. Okay, I'm going to share the screen. Do you see my screen?
Yes, we do.
Okay. Please have your cell phone ready. So this is the question, the second question of the month, and we will look into those who got to right answer this month, and we will mail the little gift to you wherever you are. So the question is, what is lung RAS in this 65 years old man with annual lung cancer screening? The previous lung cancer screening is lung RAS 1. Okay, and how we see it. Okay, that is the first image.
Nat, is there any way you can zoom the screen?
Oh, let me look. I don't even see my screen.
Okay.
Okay, let me say. Okay, let me it's too small, right? I cannot. I cannot make any changes here.
Okay. No problem.
I don't even
We
see
can
my
still see the
screen,
image. We
JP.
can still see the image. It's
just
I thought it
small.
would be better to zoom it out, but yeah, no worries. No worries.
Okay, okay.
We can still
So
interpret it.
this is the second image. The third image. And the fourth image. Okay, what will you say? Is it lung RAD 0, lung RAD 1, lung RAD 2, 3, or 4? And this is your QR code. I will give you 60 seconds, and then we will close the poll. So I'm timing us now, 60 seconds. Okay, I'm sorry for the images. May look a little bit small here. It's only like a quarter of the whole screen. I cannot change it.
And all these images are the same patient and scanned at the same time. So these different sections at different levels.
Okay. You have 30 more seconds. If you scan the QR code, and then you can pick the answer. And after 60 seconds, I will close the poll. 15 seconds. 5 seconds. Okay, it's done. Okay, we're gonna close the poll, the answer now, and we're gonna see what is the right answer. The right answer will be lung RAD 0. Why is that? Let's get back to the lung RAD version 2022. The explanation. This is lung RAD 0. Dr. Chai's talk about you did not cover the entire images, like you missing the posterior sulcus, this one, or there's no prior study to compare to, and this one will fall into this findings suggestive of inflammatory or infectious process. If I go back here, and then this person management is come back within 1 to 3 months with a low dose CT. If I go back here, you will be able to appreciate. You see the 3 in butts looking thing here? This there's 3 in butts here, there's consolidation here, the entire, almost not the entire lobe. You see more 3 in butts and consolidation here. The barrier, our natural barrier of the fissure is really good here. Is protect the infection to cross to the lingular segment here. So this is, to me, it look like either lobar pneumonia or aspiration, because we are seeing 3 in butts looking thing here. All right, let's go back to our explanation again. So this person will be lung RAD 0 and will come back within 3 months because we think this is pneumonia. And there are the latest lung RAS has the nodes. So there are like maybe like 12, 13 nodes here. This is in the node 10. Let's look at the node 10. Node 10 is lung RAD 0 within 1 to 3 months, come back to rescan. You see, all of this explanation includes segmental or lobar consolidation, multiple new nodules, more than 6 large solid nodules appear in a short interval. The time is really important. However, any pneumonia in an elderly has to come back every time you write a report. At the end of a report, have to say recommend reevaluation until clear, because you will never ever know that it's lung cancer hiding in that consolidation or not. So in the elderly, we follow it up. In a young person, pneumonia like this, don't worry about it. 29 years old, is infection, is pneumonia, just not complex, not tumor for sure. So the answer is lung RADS 0. I'm gonna pass this back to you, JP.
Yeah, thank you, Nat. Thank you so much. Nice question. All right, so I think we would be ending our session now.
We have evaluation.
Oh, we have evaluation, correct.
IT, please put up the last slide, because if we don't do evaluation, you don't get the certification of attendance. So please do, please do.
Correct. Yeah, that's you can use the QR code to complete the evaluation, and also a gentle reminder that I think, can we get the slide back? Okay, perfect. That we have a next session on imaging approach to pulmonary embolism by Dr. Sanjeev Bhala. And Dr. Sanjeev Bhala is again a professor of radiology, as a past president and STR. So it'll be a great session. So that would be on 7th of April, same time. So we'll all see you next there.
Okay, so we're done,
I
right?
saw one comment in chat box from the attendee that to give more extra time next time to 1/22.
Okay, next time. Yes, yes.
Yeah.
Thank you, thank you. We'll do next time.
Yeah. So yeah, sometimes they have like slow internet, and I guess it takes time to load. Yeah, we'll have more time next time for sure.
Okay, 2 minutes. Okay, next time 2 minutes. Thank you,
you.
Tai.
Thank you. Thank you, everyone.
All right.
Thank you,
we're
everyone.
done.
Thanks, Nat. Thanks, Diary. Thanks, the IT team. Thank you so much, Adel, Dr. Adel. Thank you so much.
Okay,
Thank
bye
you all.
now.
Thank you. Bye.